What is up, you guys, and welcome to the RT Sidebar Podcast, your go-to source for respiratory care insights, education, and inspiration. As a co-host, I'm here to reshare the thought-provoking conversations, expert perspectives, and the latest in respiratory therapy. Whether you're a student, clinician, or just curious about the field, you are in the right place. So grab a cup of coffee, sit back, and join us as we dive into today's episode. Let's get started.
Welcome, Barfly Nation. This is Matty P, your buddy Matt Pavlichko from RT Sidebar. I am coming live from Heather's mom's house. We're finishing up our holiday season. This is AKA Mumsy's house here in Harrisburg, North Carolina. We had such a great holiday season, and we hope you did too. We were so thankful for all the great memories that we have in 2024, but especially the 5 days of Barflies. It was wonderful. You had to love it. We had Dakota, Jackie, Lori, Maria, Jessica, Randy, Sarah B, and to come tomorrow, Mike and Rob. Little ethics snack to finish up your 5 days of Barflies. I just want to thank Barfly Nation and the Barfly exclusive LinkedIn group for a wonderful 2024. I want to thank Dr. JB, Mindy the APRT, JJ the RT, Anna, Angela, and our sponsor Vapotherm. So I want you to stay tuned for our first 2025 episode on January 9th, where JJ, Mindy, myself, and Anna are going to talk about what to expect in 2025. It's going to be awesome. So without further ado, the last day of Barflies is here. An ethics snack from Dr. Michael Sheehan and Rob Fishwick, live from AARC Congress. So from your friends at RT Sidebar and all the Barflies around the world and all the RTs that we love so much, Happy New Year. I hope you had a great 2024 and stay tuned for a great 2025.
A podcast by respiratory leaders for respiratory leaders. This is RT Sidebar. Stay tuned.
Lisa, you got me there on that one. Welcome to RT Sidebar. We are here again at AARC Congress 2024 in Orlando, Florida. And I get to sit between some beautiful bald men today. It makes me very, very happy.
I should have shaved my head.
I'm a little fuzzy today, too. They're going to be a little upset with me. But here at RT Sidebar, we love to have our friends Rob Fishwick from the great Northeast, Mike, Southern California. So glad to have you both. Mike, tell us a little bit about you and why we're here today.
A little bit about me. I am program director for the Associate Master Programs in Southern California. And I'm just excited to be on the podcast.
Awesome. Our students are here. Students, big clap. Students, there we go. I love that.
Indisputable this year.
That's right. They were indisputable. It's tough competition, though, isn't it? Yeah. I'm looking at you. You guys did good, though. I heard you guys did great. I'm also here, OG Barfly, like episode 8, like super OG. My buddy Rob Fishwick. How are you today? Tell the audience a little bit about you.
So I'm Rob Fishwick. I live up in New Hampshire. I'm a manager of respiratory care, pulmonary diagnostics at St. Jude's Hospital. I'm over 28 years now in the field of respiratory care. I've done a little bit of everything. I was a big DOT guy, air medical transport for a long time. Yep. And excited to be here to talk about medical ethics with my colleagues.
We're going to talk about ethics today. Oh, all right. Little ethical dilemmas. So I've had you both give lectures, webinars, type things about ethics. You guys do this fantastic. But sometimes ethics is a little controversial.
Oh, yeah.
You ready to do it? So we have legalese right here. Oh, I'm so excited. Beautiful bald men with glasses. Let's get this going. Give us a scenario that's a little uncomfortable.
So I'm going to give you kind of some of the scenarios that I've encountered, ethical standards in my life. Is one evening we were in the working at Elliott Manchester. Right? We got a level 3 NICU there, very busy ER, and my staff get a call. The NICU gets a call that there was about a 23-week-old infant born in the community. The woman's doing fine. They have heart rate. They're providing bag mask ventilation, and they're going to be in the door in about 10 minutes. So we quickly got everybody together, got all the equipment, got the NICU down there, got the radio warmer set up. EMS brings in the baby, put the baby on the radio warmer, establish an airway, get the baby on cardiac monitoring. Was unable to get any sort of intravenous access. Heart rate was about 80. They performed some questions. Did figure that the baby was probably about 42 weeks. Was able to administer some medication down the endotracheal tube. The baby's temperature was about 33, 34 degrees. So this baby was very, very
Yes.
over the course of about an hour, the team worked very, very well together. But despite all of their best efforts, they were unable to successfully resuscitate this premature infant that was born. So the ethical dilemma that I want to present to you is, did we do the right thing? And what do I mean by did we do the right thing? Did we do the right thing in utilizing all those resources, right? 3 to 4 respiratory therapists, neonatologists, mid-level providers, taking NICU nurses away, ED providers, ED staff, for an infant that, in my opinion, was not going to survive.
Okay.
In my opinion, had no viability.
Okay. So,
Can I ask, please, how long ago was
Top of the spring. It was actually a week prior to that.
so a little bit, it's less than a year.
Yeah.
Okay, so within the last year?
Yep.
Okay, okay.
Within the last.
That's important for me.
Tell us why.
Well, so, about, I want to say about between 6 and 10 years ago, there was big news, the youngest baby born record was 380 days, 21 weeks.
Yes.
Now, that goes back to what we learned about 24 weeks being the week of viability, right? Pulmonary capillaries get close enough to get gas exchange, and our technical advances. So in reality, at 22, 23 weeks-ish, are we able to these days move that 24 weeks down in that emergent situation? That becomes the biggest question for me. And I think the answer is yes. And you know, I believe that in that case, the chances of survival low, yes, but if there's a chance,
So you're saying there's a chance.
there's a chance, yeah. You know, that's just where I go. I get to cut and dry because I'm an old DOP guy too.
Yeah.
And you know, and it's a big deal to me personally. And so if there's a chance, there's a chance. Yeah. You know, but if your argument is resources, the resources are there for you.
Let me have I keep counterpart to that.
Sure.
That's why we're here.
So if you look, so correct, if you look at the data from the Vermont, if you look at Vaughan, right? Vermont Oxford Next-Look data, they are 23 weeks now, it's considered right, the new 24. Right. These are babies that are born in the most optimal conditions possible,
True.
right?
That's true.
Right? They are born in centers that specialize with OB, right? That deliver high risk premature infants with a team to provide the highest level of neonatal resuscitative care and level 3 or level 4 neonatal capabilities, right? And even with all of that, now let me ask this question: what's the percentage of spots?
So, to home with no morbidity,
Right,
no morbidity is 1%.
1%.
True mortality, I have to look at it, but I'm going to guess between 5 and 10.
5 or 10% spread. About 10%. About 10%.
It's a tough. If you're talking about resources, different conversation. Right. But if we're talking specifically the age of the child, NRP says this: greater than 500 grams and or 23 weeks. So you can be one or the other. So the other piece is how do you know you're 23 weeks?
And that's a good point.
Yeah.
And that's a good point because you can be 23 weeks and have PPs for months. Right. So that's the argument that you kind of make there. The argument that I make is our job is to save that's our job. And in an instance, and you know, we were talking slightly about something similar to this before. If parents who are the primary decision makers, if they make that choice and they want you to do that, you can do that. Just like if a wife whose husband is has a DNR, you can rescind that DNR. It's not others. And what from an ethical standpoint, do the authorization of the patient's wife in this situation, being the owner of the patient's wife at that moment, because the patient can only make that decision and the wife can make that choice. And if we have a responsibility in that case to perform CPR on the elderly patient, why wouldn't we have the same responsibility for them, regardless of percent chances of survival?
Let me go back to my original, if I can go back to my original.
Yeah.
So part of my original argument was obviously the amount of resources required, right, for this micro preemie who we only estimated at 22 or 23, born at home, was he never recovered.
No, never.
Never.
Okay.
Right? That was part of the strike problem. I left that.
No, you said it. You said
Okay,
it. You said
Yeah.
it.
And for our students, you don't call the code until they're
Right. And they were
Everybody
never,
dies full.
right? This infant had less than 1% chance of survival. So let me present it a little differently. I agree that as providers of health care, we have a moral obligation to do right or do the right thing. Right. That, I know we're not going to do that, right? It's do the right thing. I think in this situation, my opinion, I think what we should have done is we should have taken the baby. We should have explained to the parents that it's not going to survive. And we should have given that baby to the parents, and we should have put the parents in a comfortable place. And we should have supported them. It's what was a difficult time, opposed to, just hear me out,
No, I'm agreeing with you.
watching
100%.
them, watching. And again, we all know that statistical data around pediatrics is when the parents get to witness the resuscitation, they psychologically do better, right, in the long run versus walking in the middle. And then we come and tell them that their child died. I don't think that the resource allocation in this case, and the fact that this child had less than 1% chance of survival, in my opinion, equals what we put the parents through having to watch the substitute.
I understand.
Yeah, yeah.
So let's remove and actually let's separate them out. Let's have the resource conversation be a little bit separate.
Sure.
Because when you mix them together, my brain throws the resource conversation completely out because to me it doesn't have that same thing. So, but I want to clarify your argument because I understand it correctly. I agree with you. The argument is, with the chances being so low of survival, let's let the parents spend as much time with the child as possible.
Yeah.
That's your argument. And that's a hard argument to argue against. However,
Yes, those are very tall flamingos that pass by the podcast while we're talking about medical ethics. That's fun times.
I understand the argument, and it's hard to argue against. However, isn't it also our job to find a balance between the two? And when we bring that in, we can bring resources back in as well, because our job is to consider resources. Now, from a management perspective versus a bedside therapist perspective, that consideration of resources is drastically different. And we recognize that. But we're talking, and you're speaking about it as a manager.
I am.
And I'm talking about from that bedside of our team. and saying, okay, that bedside RT is saying, no, I want to save, I want to help this child, right? But and so from a resource standpoint, we owe that child to 100%. Your question is, how much? Right? That's really where your argument is. Should we have wasted all those resources? Wasted is a or not. That's what all matters, right? Should we have used all those resources? But I think if you ask 100 people, you'll get 100 different answers, and probably 100. You won't get 50-50 across that board. You won't get 70-30. You won't get 80-20. You won't get 100 people agreeing with the tribe. You'll get probably 100 different people that have something else to bring to that table. But in the end, I think there's a balance between using the resources, helping the child. And I come from a NICU, 61 bed level 3 in Southern California. We would bring the parents in. We don't walk them out. We bring them in. We walk them through what they're doing for their child. And they see how much, they get to see them, how much you care and how much this team wants to do good. And that can be comforting. And they're there able to spend time with the child while you're coaching the child. They're there able to hold that child. They're able to have what you're suggesting we should have spent more time doing, which is letting them spend time with their child. They're there able to do that because we have a responsibility. We don't lock them out. And I'll be honest, even with an adult coach, I don't agree with pushing family out. I believe that, if they're
not getting in the way.
Yeah, if they're hysterical, then yes, they probably should be removed for their sake. But if they're not, and we can tell them what we're doing and show them how we're helping, that can be comforting in itself. And I think there's a lot to be said for that.
Could it be traumatic?
Absolutely.
It can be traumatic, absolutely. But one of the things that we do with parents in a NICU, right? I know we're not in the NICU here, we're in the ER, and we're taking them home. One of the things we do with the parents in the NICU is get them involved. We let them know this is what you're going to see. This is what to expect. Trust me, it's perfectly normal. It's going to be a little shocking at first, but I promise you, these are normal things. And we do that in the delivery room, code Matt, in the warmer, in the delivery room. We bring dad over, and I've been in codes where I've had to tell dad, hey, you probably don't want to give them to your kids. You can if you want, but you're not going to want this later. And they turn it off, and then I bring them over and I show them, here's what we're doing. Here's why we're doing this. Here's what's happening. And seeing the team calm the parents down. And that just, to me, that can be so comforting in those situations.
And I don't disagree with that, right? Let me say this. In the United States, we have the privilege of having a resource-rich environment.
Correct.
Right? We do. If you look at other places across the world that do not have resource-rich environments, even at 28 weeks of gestational age, right, there's no resources to take care of the child. Right? So I think we're privileged that we got to your point, we are privileged that we have a resource environment that we could stop everything else we were doing. Again, I debate. We stopped everything else we were doing. We didn't care for all of our other patients and poured resources into what I think. I actually think it wasn't the best decision. It had a pronounced negative effect on the staff because it didn't survive.
There could certainly have been a better use of resources in terms of staff. I would agree. We do it with deliveries, and then these are the people that go to deliveries, and what else is done? We could certainly do it in that situation as well. I was there. I don't know how many people were pulled from the NICU to go to ER, but if it was a significant number, then that's something you reevaluate with regards to procedure. Should this happen in the future? This is how we can.
So the one thing that I got from both is ethics are values. It's a value system, okay? Right. And you try to break it down the best you can. You guys will taught me that quite a bit. The one thing that I get from this is, do the parents understand? So part of ethics is consent. Do they really know what's happening? Do they understand? So could be comforting be traumatic, but to me, I feel it's necessary. This is what we have to do to do it right.
Most sentencing procedures will talk about consent, except in an emergency situation.
Correct.
Yes.
Consent changes,
Yeah,
especially in
sure
the
does.
pediatric
Becomes implied.
population,
Yeah,
right?
it becomes implied.
Yeah, right, it's implied consent.
It's implied consent. But the right thing to do might not be what's right for the baby, but the right thing to do is to inform the parents. That's the human thing to do.
Yes.
Right?
Yeah.
Be human. That we all agree. So that's what I love about ethics. We can have differences of opinions, but we all end up coming together in a balance of that. You know what I mean? You're like, okay, I see your point of view. I see your point of view. And I know the bar flies are going nuts right now. They're going, no, no, no. I'm gonna ask your students. Did you resuscitate?
Why
Or
don't
do
you
you
guys
not
come around this side
resuscitate?
real quick?
This one come over? All right, let's get them involved. All right, students. Here we go. Okay? Do you resuscitate or not? All right, come on, you gotta get closer.
Hopefully.
I mean, I will be able to say that we didn't try.
I like it. Anybody else?
Once you're done that, that's what we're supposed to
It's just the wrong incentive. Leave somebody that just.
Okay. Ladies, agree? I think it's a tough one. I think it's a tough one. And on our next episode, when we're talking about ethics, we're going to dive into something else a little deeper. What I'm thinking, gentlemen, beautiful bald men of my life, is that maybe we need to have like a little ethics corner where we just do one every once in a while, bring up an interesting one, maybe lots of the news, and we break it down and talk about it. Would you guys be interested in something like that? I love it. So we are going to finish up because the ARC is getting wild. Get some out of here. Guys,
Yeah.
thank you so much. Being my friends, being here at
And
ARC with me. I think it is so much fun. I know we wanted to go a little longer, but I thought it was a good one.
Thank you.
Lisa, was it okay?
It's always a pleasure.
As long as Lisa says it's okay, we are good to go. So we're RT Sidebar. We're here with the students. We're here doing awesome things. Mike, thank you so much. It was great to meet your family and your students. Rob, as always,
Thank you, Matt.
great to see you.
Pleasure.
This is RT Sidebar at AARC. Make sure you're in Phoenix next year, right? Phoenix next year. Come to AARC to talk to awesome people like us. Why wouldn't you? Absolutely. So for RT Sidebar, stay tuned. Be back.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Pavlichko and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.
Thank you for tuning in to the RT Sidebar podcast. I hope you found today's episode as insightful and inspiring as I did. If you enjoyed the content, don't forget to hit the like button, subscribe to the channel, and turn on notifications so you never miss an episode. Got questions, comments, or a topic you'd love to hear about? Drop them in the comments below. I'd love to hear from you. Until next time, keep breathing easy, and I will see you in the next episode.